Hi, Lisa.
Hi, Dr. Kiltz. How are you?
And hello, everyone. How are you doing today?
Welcome. We have another great Q&A webinar scheduled. We wanted to be able to just check in during the week as well, catch you for some nice quick questions, let you know what's kind of going on our end, hear from you to see if anything new has popped up since we do our wonderful monthly Q&A webinar, the longer 1 hour session. We will have that again Tuesday, October 25th. At 5 o'clock, and that will have the free IVF giveaway component. But today we just want to take a break and just try to get through as many questions as we can.
We're doing a 30-minute Q&A, and we'll talk a little bit about some other things real briefly, but why don't we start in right with some of the questions coming in?
Yeah. The first question is, hello, I would like to know the current statistics of pregnancy and live birth rates for donor-egged IVF cycles.
Oh boy. So this is always ongoing. And I'm not going to speak of it right now because I don't know our most current numbers. But if you look back at our CDC SART numbers that we last reported, we're doing even better than that. And so we're over 50% right now. So we're doing a lot of frozen eggs, creating a lot of frozen embryos, and we're doing both day 3 and day 5 transfers. And we're incorporating a lot of the immune modulation and diet treatment into those transfers also. So basically the donor eggs are doing in the 50% range, and we've been very happy with them.
Great. Next question.
Give a call or an email to our donor egg team and we'll get you that information.
Yep, absolutely. The next question is, can I use, Menopur, Mironal, 75 IU sub Q instead of Menopur. It's cheaper, and I did research that says they are exactly the same. Mironal?
Let's see. So I'm assuming that's from another country, and getting it from another country may be a resource that we can't give you a yes or no, but people do it. And I think that essentially these drugs are made across the board around the world and very similar. So my bet is it's probably equivalent.
Great. The next client is signed up for a 5K that is the day before her stimming cycle begins. Can that be bad or detrimental to the success of her cycle because of inflammation or any other reason?
So 5K run, and running is a fight or flight activity. It stimulates epinephrine and cortisol and insulin and inflammation. So I think that yoga, massage, walking, slow it down is probably going to be the best thing you can do. That fight or flight activity is a downside when it comes to success rates for whatever you're doing in trying to conceive, whether it's with assisted reproductive technologies or it's natural.
Great. What is the prognosis or success rates for unexplained infertility and IVF?
Well, most of our patients, I believe, are in the unexplained idiopathic infertility. I believe that forms into the immunologic causes, but basically everything is really age dependent. The under 30, it's in the 40 to 50% range per cycle. In the 30 to 35, it's in the 30 to 40% per cycle delivery rates, depending on ovarian reserve and things like that. And then the over 35, it's in the 30% range, and then over 40, it's going to drop to the 20% range. But basically, since almost everyone falls into that, their tubes are open, they have regular cycles, their sperm looks okay, you're falling into, and that's probably the 50% category, you're falling into that idiopathic range that those numbers are pretty good. We're really pushing a lot more to be more aggressive with the autoimmune evaluation and treatment, and definitely the ketogenic diet, which has a lot of evidence that it supports and reduces inflammation.
Absolutely. Thank you.
And the other thing on that idiopathic unknown cause is you should search for endometriosis, which is the silent cause for so many people that think they have an unknown cause. Endometriosis causes local inflammation around the ovaries, the tube, and the uterus, and adversely affects both implantation, egg and sperm interaction. And so I think it's really important to consider a diagnostic laparoscopy with or without a hysteroscopy to look for that and treat it.
Great. The next client is wondering how we're able to offer prices at such a reduced cost.
I started this business 20 years ago, and I started at $2,000 for an IVF cycle. We've remained affordable. That's my motto and my dedication to what I do. And so affordability has just always been something we've started with. So we didn't start with prices way up here where it's difficult to bring them down. We started with pricing down here, so we don't have that force to keep our prices high. And our dedication is to affordability, quality, and access for patients globally. And we see patients from around the world. And I also believe that one IVF is not enough for most people, if you really look at the numbers and understand that. And so persistence in whether you do natural anything or some ovulation induction IUI or IVF, we work to encompass that and make it affordable in everything we provide.
Great. So the next client wants to know what we need to do to get started with IVF at CNY Fertility. They already had their phone consult, but they're not sure where they go from here.
Give us a call back. And typically that's really it. We work to keep it simple. Much of it has to do with the medication protocol we'll recommend, ordering your meds, and then calling with your menstrual cycle, and then giving you instructions, helping you find someone to do your monitoring locally. If you don't have someone, we'll help you do that. But we really work to simplify as much as we can in the process. So it is a matter of calling our office and talking to one of our nursing team specialists, or texting or calling me.
Absolutely. Do we see an increase in successful cycles and births following a hysteroscopy, laparoscopy?
I definitely believe that laparoscopy, hysteroscopy has a positive value, and whether it's helping you just get pregnant naturally or it's going to help with either IUI or IVF. Endometriosis and pelvic inflammatory disease, which isn't necessarily a bacterial infection, but maybe an autoimmune condition which is related to endometriosis. I believe it's related to gut health. The colon, the rectum, the bowels in general are the harbinger of most of the inflammation in our body. The majority of lymphatic or lymph tissue is surrounding the bowel, which can be treated with either excising endometriosis or local inflammatory cells, cauterizing or lasering them, or just identifying it and giving you something to put your hat on that you understand that inflammation is a key. We do a washout, so just rinsing the pelvis and lysing adhesions really helps a lot. The hysteroscopy part of it is looking into the uterine cavity, and by cleaning out the uterus, there's some evidence that may help. It may modulate the inflammatory system. So I think those are important things to do. And I've seen so many patients conceive, one, naturally after doing it, or assist and increase the odds with either IUI or even IVF cycles. The problem is that the studies don't clearly answer the question, but you're not a study, you're an individual, and when we find things that help increase your odds, because so many people do not want to go to IVF or feel that it's out of their financial capabilities. We want to make sure that we're giving them every opportunity to identify and treat those areas that can benefit.
Great.
And your OBGYN physician can easily help you with that. If not, we'd be glad to help when we see, again, patients coming to us for that. We do it in the office or one of the local hospitals as outpatients.
Absolutely. The next client just started her first IVF cycle but had to stop after 7 days because she had one mature follicle, and they ended up switching to IUI because of that. Her question is, she thought that the IVF medication was supposed to increase the follicles, but not sure why only she ended up with one.
Well, in general, 38 years ago, Louise Brown had the first successful IVF baby with a natural cycle, no medications. Over the years, we've moved to using these medications to stimulate more eggs, but we're finding that for some patients, the extra injectable medications don't necessarily make more eggs. And so it's still possible with one egg to make a baby with either natural IUI or IVF, but the probability goes down. It could be that you have plenty of eggs, but under some circumstances, the one lead follicle or egg seems to suppress all the others, and then you only get one. So it may be worthwhile canceling that, starting over, seeing if you do better. If you don't do better, then it still may be worthwhile for you to do that one egg or two. I've had some instances where we thought there was only one, we still got 4 or 5, so you got to look at those instances and consider that. And or if you're not doing better on the high dose medications, then go to either a natural cycle or a mini cycle with either a combination of just letrozole or Clomid, or letrozole, Clomid, and a low dose injectable medications.
Great. The next client had a question about the endometrium. She just did the IUI today and was told to take endometrium. What is the reason behind that, and is it really necessary? How long should it be done for?
So endometrium, which is a progesterone supplement, a vaginal, Crenone, another progesterone supplement, or Prometrium, all may enhance the endometrial receptivity and the luteal phase part of the cycle to help with implantation. Although it's controversial whether or not these things are necessary, there is no evidence that they're harmful. We just don't know exactly in whom may be experiencing the luteal phase defect. The biopsy diagnosis is really not utilized much anymore, and it's generally reasonable. The cost isn't that much, so we're finding that the combination of the luteal phase, progesterone, in some cases a low-dose steroid, and even an antibiotic may help further enhance the local environment to help reduce the inflammatory reactions and increase the ability of that embryo to stick. But another way that we've been doing it is also to follow progesterone, estrogen levels. We'll look at thyroid levels just before your cycle, sometimes at the time of ovulation, and then mid-luteal, a week after ovulation, so that if we want to modulate either estrogen or progesterone therapy or even thyroid therapy, then we can do that at the same time. So there's a lot of idiopathic infertility, we're idiots, unknown cause, where we do a lot of empiric therapy without a lot of solid evidence. This is challenging for all of us scientists who like to know the answer. But in fact, there are really not a lot of solid answers, so we wind up doing a lot of empiric therapy that thankfully works enough at a lower cost that is reasonable to do. So if you're having problems with that supplementation, there are others to try and or just follow levels that may be helpful.
Great, thank you. The next client is asking about our military discounts. Are they only for active duty military, or what about veterans and retirees?
Well, we're really working on that, and I think that for both active veterans and retired, and we're working to incorporate that discount for all military that have served active or in the past. And when it comes to the significant discounts for those that have military injuries, then that's something again to call our service, talk to our financial team, and they'll help give you some counseling and help you find the most affordable source.
Great. The next client teaches Bikram Yoga and practices regularly. What are your thoughts on doing Bikram Yoga and IVF?
I'm not an expert on yoga. Bikram or?
So it's a high heat. So you are often in a room with the temperatures raised to over 100 degrees following an intense sequence of yoga.
Heat in general isn't as good for the body, and especially if you're heating it above body temperature.
Yes.
And so light fertile yoga is generally my recommendation, is to slow it down. Those things feel good, don't they? They make us, it stimulates the endorphins, and that makes us feel good. So, like anything, you can find those people who find success in that. If you're suffering from infertility, maybe it's time to change a little bit of the things that you've been doing. Now, this is my unscientific opinion, so I would just say cool it down and slow it down. Put your feet in the hot tub. Do a little bit of the sweating, but minimize it as much as you can.
Great.
And remember that the environment can adversely affect sperm and eggs and uterus, which may have a longer term adverse effect, and we just don't know how long those things last for.
So the next client is 37 years old and weighs about 94 pounds. When they initially started the IVF medications, which we had to switch to the IUI due to the follicle issue, we were told that you recommend more of a paleo diet. What would you recommend to someone with a low weight and no issues with insulin with a paleo diet?
Well, increase the fat, increase the caloric intake, and because whether you're normal weight, low weight, or high weight, the amount of carbohydrates can adversely affect the inflammatory process in your body, which adversely affects the mitochondria and all sorts of cellular functions. So I think that's really an important thing to look at. Increase the fat that you eat. Looking at some evidence that potatoes and rice, being more simple sugars, absorbed faster, maybe have a shorter glycemic rise, although because the complex carbs may have a longer release into the bloodstream from the gut. So really the simpler sugars may actually be better, in my opinion, and maybe moving to once a day. But when you need to keep the calories in, then you may be eating more meals. But the more you can do with keeping fat higher, fat is calories. More calories per gram of fat than there are in anything else. So that's still my basic recommendation in all this. And most of our dietary recommendations come from the food industry that sells food, and I believe that our recommendations have been wrong for a long time, which has led to many of the problems that we're experiencing today.
Absolutely. Great. What are your views on flying and travel during the first trimester of pregnancy, especially for our clients who travel from out of town?
Low stress travel is better, and I think in general flying is safe and okay. But if it's a stressful process, then it probably isn't good for you. And if you're traveling to areas which are indigenous for viruses like Zika, you want to be cautious, and you're working to have a child and try to keep it and make it healthy. And so somehow sticking around home may be the safest in all of this. So, but I think it's safe overall.
Great, thank you. So the next client is doing the keto diet and is having some trouble. Is it okay to have a snack between meals? And what about husk powder to use in recipes?
Husk powder from...
I'm not familiar with husk powder.
I'm not either.
Corn husk?
My biggest concern about a tremendous amount of micro phytochemicals is that they are antigens that have an antigen antibody reaction in our bodies. It's like dust in the wind, which gets into our windpipe and absorbed into our lungs. Anything we consume in very microparticles, even without that, makes it easy to get into our bloodstream, and then those microparticles actually get incorporated within all of our cell walls or into our cytoplasm or into our mitochondria, which then has, again, that antigen-antibody reaction, which is probably not good.
Yeah.
So I try to narrow my diet to healthy fats, bacon, eggs, butter, beef.
Yeah.
That's my preference. But I believe that if you're doing anything, you're trying to have the major meal in the evening, even if you're adding more carbs, or you're trying to spread them out to 12 hours. Anytime you consume a carb, even if it's I'm assuming husk is a carb, it's going to stimulate insulin, it's going to stimulate your inflammation, and it's going to stimulate hunger. So it's really hard to go without eating those frequent meals. If you read Maria Emmerich's book, we highly recommend her diet. She does incorporate a lot more variety.
Yes.
And so I think she's a great source, and she's communicated directly with many of our patients. So I recommend you email Maria. She does some consultations, and she really has some great recipes and ideas.
Absolutely. What's your opinion on conceiving naturally with less than 4% strict normal sperm morphology? Research seems to be unsure.
So the morphology testing of sperm is highly inaccurate in my mind. Definitely there seems to be some correlation, but it's not across the board. I think that depending on the age of the woman, the number of years you've been trying, or how much time, or other factors that go with it, I believe that de-stressing for the guy and the woman, shifting exercise, lightening it up, and the keto paleo plan for both, yoga, and really even trying some simple things like IUI without going to the more advanced things can be an easy enough thing by concentrating. So doing a sperm wash may help concentrate the more normal morphology away from the less normal, and so that inseminated may be better. But again, back to look at Theralogics.com, the Conception XR, and antioxidants, and really the best antioxidant we know of is fat. It really reduces inflammation, and by reducing the carbs that increase the inflammation and cause the mitochondrial and the DNA dysfunction that cause the DNA fragmentation and the morphology issues. So I think it's really slow it down, ketogenic, paleogenic diet, depends on how bad it is. And if you look at good calories, bad calories, Gary Taubes, and The World's Turned Upside Down by Richard Feynman. Those are some of the books that I've gone to. And also dietdoctor.com, Andres Ehrenfeld, and then Dave Osprey, Bulletproof Coffee. Really some great ideas that are completely opposite than most of us in medicine have recommended for years. But I think it's a good start. So morphologically, natural pregnancy still can happen. Try to heal it naturally first. And if that's not working, think of some washed samples with IUI, but make sure you check the female partner also.
Absolutely. So the next client, the couple seem to have zero male issues, but the female, who is 39, has a low AMH. She's done three unsuccessful medicated cycles, 1 IUI and 2 IVFs. The IVFs also had PGS, and all 10 embryos had abnormalities. Insurance has run out. Should they keep trying with IVF? They're quite costly out of pocket. So low AMH, 39, and all seemingly abnormal embryos.
So never give up. PGS isn't 100%. The male component can contribute to abnormal egg embryos. And so just because something looks normal doesn't mean it's normal. And age and AMH and a history of multiple failed IVF cycles with abnormal embryos may be an indication to look towards donor eggs as the best success. So with that type of story, you're probably looking at a 1 to 5% delivery rate with IVF versus a 50% plus with donor eggs. So Not to say that it can't happen naturally or by doing another cycle, but those are the odds in this process that it may be time to look to that other area. Don't forget laparoscopy to look for endo, which can cause damage to the local environment of the eggs, cause a reduction in ovarian function and quality. So again, and that dietary change, where I've seen it between the laparoscopy and the dietary change, improve eggs, embryos, and a conception can occur.
Great.
But donor eggs definitely is the way to look, or adoption.
So the next client says that her husband has had a vasectomy. They decided that IVF is the direction that they're going to go. And how do we start? Do they test to see if he still has viable sperm first, or they start with checking her eggs?
Well, it's always a couple that goes through the process. So if you've had a vasectomy and you're ready to do IVF, an exam of the testicles, normal size, no other abnormalities, you're 98 to 99% you're going to have sperm. Occasionally we'll do a test biopsy if it's been more than 5 to 10 years since your vasectomy, which is a simple needle stick to say, okay, we have sperm. We can actually take that sperm and freeze it and then be prepared to use it for IVF. You always want to make sure that you're looking at both partners here, the egg source and the sperm source and the uterine source, to make sure that they are all as healthy as can be and identify any other potential problems. So make sure that the uterus is normal. I recommend looking at the fallopian tubes because abnormalities of that can be harbingers of chronic inflammation and adversely affect success rates. And then look at AMH, ovarian reserve with ultrasound is a good way to go. So a PESA, percutaneous epididymal sperm aspiration, is a simple 2-minute treatment to retrieve sperm. Under rare cases, we need to actually go into the testes and or do a procedure with general anesthesia and an open biopsy, but most of the time we can simply do a local with a simple aspiration of the epididymis.
Great.
It works very well.
The next question comes from a same-sex female couple. She and her fiance have been trying to conceive now for over a year. Her fiance, who wants to carry the child, has been diagnosed with PCOS and endometriosis. She believes it's mild. So far, they've done 6 IUIs with only 1 chemical pregnancy. They've now done 1 IVF with a miscarriage and only have 3 embryos left. What could be a cause for why they aren't conceiving? They're worried they're never going to have a live birth. And do you think they would have better success with fresh or frozen transfers?
Frozen transfers are doing better than fresh. PCOS and endometriosis are inflammatory metabolic disorders that are related to a high carbohydrate, low fat diet. Switching the ratio will help. If you haven't had a laparoscopy, and it sounds like you may have had that, to look again and treat the endometriosis. Ovarian acupuncture or ovarian drilling, it sounds like a terrible thing, but it's little tiny holes in the ovary that tends to also help in increasing outcomes. A hysteroscopy and endometrial biopsy can help. And then how do you better treat the metabolic disorder? Ovasitol or metformin. We've been using a lot of low-dose naltrexone, LDN, that really helps in blocking the opiate receptors, which are probably a factor in all of this. And then adding intralipids or intravenous immunoglobulins, and then potentially treating with things like Neupogen or Prograf, which are anti-rejection drugs, which are important. And then we're using a lot of Lovenox and baby aspirin because the actual cause of the immunologic miscarriage or failed implantation may be related to the blood clotting cascade. And so inflammation triggers blood clots, and using Lovenox and baby aspirin may help reduce that inflammatory clotting mechanism, along with a high-fat, low-carb, no-sugar diet. I think can be really, really, really helpful. We've been sending patients to Bikram Fertility in Toronto doing leukocyte immunotransfusion, LIT, very controversial area that takes a blood sample and takes out the white cells, typically from the male partner or a male or a donor source, and injecting the white cells under the skin. The IVIG and intralipids may be sort of the other treatment for that, which we've seen some good success rates. So I always say if you're failed implantation with good embryos or miscarriages, look towards the immunologic side of things as the greatest and most likely cause of that, and look to treat that area first.
Great, thank you.
One or two more questions?
Yeah, that sounds great. How often do you find that endometriosis is asymptomatic?
More and more I'm reading, and the more and more we've been doing diagnostic laparoscopies on patients with no symptoms other than they're infertile or they've had repetitive pregnancy losses, we're finding endometriosis. And so there's evidence that at least 50% of infertile women have silent endometriosis. And a laparoscopy, hysteroscopy, although it's often discouraged by many of the OBGYNs out there and some fertility experts, we're finding a significant number that have endo. You do the laparoscopy, hysteroscopy, many of those are conceiving naturally or enhancing their success rates with either IUI or IVF treatment. So I think it's more common than we understand. Today I did 3 laparoscopies in the office. One of them had severe scar tissue of the ovaries and bowels, the other 2 today didn't have any. Last week I did 3, and all 3 had some endometriosis. So it really is much more common. I believe it's the most common part that we just forget about. And so we lead people down this long trail of evaluation and treatment, but forget about the laparoscopy, hysteroscopy early on that may help many people conceive and deliver, even the fact that they don't have any outwardly signs or symptoms other than they're infertile.
Great.
So one more question for today.
Sure. Last question. This client's last fresh IVF cycle had 7 follicles at the retrieval, but only 2 eggs were retrieved. Were the follicles empty, and what could have caused this?
Well, this is one of the biggest challenges with infertility, because you see follicles or cysts in the ovaries. We always equate that to an egg, but we often may find that there's a lot of empty follicles where the egg probably never developed, or it degenerated, or it's possible it was released prematurely. That's, we believe, is less likely because we can aspirate the fluid around it and we should get an egg, or we don't. But in one cycle that may happen, the next cycle you get 7 eggs out of 7 follicles. So, you know, this is what we're learning. And not that we want IVF to be a diagnostic test for you, but it sometimes works out to be a diagnostic test to help identify a client yesterday, her second cycle, we got eggs, but we got nothing to fertilize twice in a row. Many of them were degenerative. So this may help answer some of the questions that are going on. I personally believe it helps answer the local inflammatory process. We're beginning to look at uterine and ovarian artery resistance, which may help us answer some of the questions about vasculitis. So imagine this autoimmune condition within your body in the bloodstream, which may cause a vasculitis like coronary artery disease. It narrows the vessels, it reduces the blood flow to the organ, uterus or ovaries or testes, and we may be able to better identify that as a cause, and treatment with either Eastern or Western. And incorporating both of those ideas into this, I think, could be really helpful. But my bet is it's a diagnostic helping identify that there's more inflammation going on than we understand. And the more I'm beginning to read about mitochondrial inflammation, mitochondrial disease, I believe that it's all linked to excessive sugar, and it's a really hard one to understand. But we've seen so much success by working in that area. but it's just another idea because there's so many different things that we can bring into play here. And we're going to, let's see, so next week I'm going to the American Society of Reproductive Medicine conference in Salt Lake City.
Yes.
Hopeful to bring back some new ideas, talk to many experts from around the globe, and incorporate everything and anything we can to help in accessibility, affordability, and simply our job is to give information to you that may help you to speak with your local fertility expert, seek out some advice, some questions, but question us, question everyone out there, because the more questions we have, the more we'll begin to seek out and help you on your journey. But keep at it and incorporate Eastern and Western into the process.
Absolutely. And we will be back Tuesday, October 25th from 5 to 6 p.m. with another Q&A webinar as well as our IVF giveaway. When you register for the webinar, you are automatically registered for the IVF giveaway.
So God bless, and we see you in a couple weeks. And thanks to Brad for helping us on behind the camera.
Thank you.